right, is it working? Testing, okay. Okay, if we can get started. Are there any questions so far? I know some of you have been emailing me, and that's fine. But anybody got anything, problems they need here? All right, what I'm going to do, I'm a little behind, obviously. So what I'm going to do is I want to cover just a couple more of the assays. I'm going to cover the radioimmunoassays, and I think I want to cover the complement fixation assay because that's a little bit more complicated. The immunofluorescence I'll let you look at yourself, and then we'll go on to the topic for today. All right, so this next group of assays, the radioimmunoassays and the enzyme-linked immunosorbent assays, they're basically, in principle, they're identical. The only difference is the readout. In the radioimmunoassays, there's some sort of radioactive tag that's used, and you measure radioactivity. In the ELISA, you attach an enzyme, again, either to the antigen or the antibody, and then you measure enzymatic activity. Now, this is the first group of tests that we come across that do not require lattice formation. All right. So obviously, these tests have had to devise some way to detect those small immune complexes, and that's what's the key in that test. And because they're detecting these small immune complexes, these actually are more quantitative and more sensitive than the other types of tests. All right. Most commonly, it's used as a competitive radioimmunoassay or ELISA for antigen. And in this thing, it's a two-step procedure. What you have to do prior to the actual test, you have to determine what's the appropriate amount of antibody and antigen. In this case, the antigen is labeled, again, either with an enzyme or with a radioactive tag. So you're trying to determine what's the best amount of antibody and antigen to use so that essentially all or almost all of the antigen is complexed with the antibody. All right? So once you've determined that, then the test is the following. You take that predetermined amount of antibody, the predetermined amount of labeled antigen, and then you put your patient sample in, which you're interested in measuring this particular antigen. Well, what's going to happen again? Just as in the hemagglutination inhibition assay, in principle, this is the same. The patient's serum, if it's has the antigen, will compete with the labeled antigen for binding to the antibody, and some of the labeled antigen is going to be displaced because of the competition. Now, the whole trick in these tests is how do you detect those small immune complexes? A number of different things have been done. People have precipitated the proteins with ammonium sulfate and then count either the radioactivity or measure the enzymatic activity in the ammonium sulfate precipitated. Obviously, the enzyme is going to have to withstand the precipitation with ammonium sulfate here. Other methods have used anti-immunoglobulin. They take an antibody directed against this antibody, just like the Coombs reagent, and precipitate with the second antibody. But probably the most common way of doing it is actually just to immobilize your antibody on a solid phase. If you immobilize this antibody on a solid phase to begin with, and it can be on the side of the test tube, it can be on a bead. There are a lot of different variations on this thing, but in some way immobilize this antibody. Then it's very simple. That's all you do is pour out. If the antibody is coated on the side of a tube, you just pour out the contents and wash it, and you've got this complex. Okay. And then of course, you set up a standard curve where instead of putting the patient's serum in, you put a known amount of this unlabeled antigen, and then you can relate how much of the labeled antibody is displaced by a certain amount of your known antigen, and you can set up a standard curve and then read off from the standard curve from your patient sample. And as I said, these tests are actually, because they don't require antigen. They don't require lattice formation, are very sensitive because they detect even the smallest immune complexes. Anything bound to this antibody is going to be detected by this technique because it's immobilized. Now, these tests can be also done in a non-competitive manner, and this is, for example, one for antibody detection. So if you want to detect antibody, what you do is you stick antigen on the solid phase. Then you follow with the patient serum, if it's in your that you're trying to measure the antibody against, and then you follow up with a labeled anti-immunoglobulin. Again, this could be radio-labeled or it could be enzyme-labeled, and then you measure the amount of the labeled antibody that binds. Or you can do it for antigen detection. And the only difference is what's stuck on the solid phase is the antibody molecule. Patient sample has the antigen. If it binds, Then you add the second antibody that's labeled. This is another second antibody to the antigen, and then you can quantitate that way. So you can do these in either a competitive or a non-competitive fashion. And they're very quantitative. In fact, they're the most sensitive of the tests. All right, I'm going to skip over this section on the tissue-associated antigens. It's immunofluorescence. If you have any problems or any questions on it, we can deal with them in that conference quiz, okay? So I'm going to just skip over these things and go to the complement fixation test because that's a little bit... Okay, complement fixation test. Again, this is a test that does not require lattice formation, okay? But what you do in a complement fixation test is you set up two tubes, basically. In one tube, you're going to add, what you're trying to do is you're trying to assay for antibody. That's the most common way of doing it, so that's the way I'm going to describe it. So we're going to try to measure if there's antibody there. So we put some of the patient's serum into two tubes. One of the tubes gets antigen, but the other one does not. So antigen to this particular, that is directed against, the antibody is directed against. Well, what's going to happen? In this tube, if the antibody is there, the antigen will bind to the antibody. Of course, nothing's going to happen here because we haven't added anything. The next thing to do is to add some complement. And a known amount of complement is added to this. So what's going to happen? In here, you have now antigen-antibody complexes. So the complement can bind to the antigen-antibody complexes, and it will be fixed, and it will be consumed. All right, this is complement fixation. Of course, in this tube, nothing's going to happen. There are no immune complexes there, so nothing's going to happen to that complement that was added to the second tube. All right? The next step is to add an antibody-coated erythrocyte. And again, this is a reagent. This is a standard amount of an antibody-coated erythrocytes to each of these tubes. So what's going to happen? Now we've got immune complexes there. So this complement that has not been used up can bind to those antigen-antibody complexes, and it will get fixed. And what's the end product after you go through that whole complement pathways? What's going to happen to these cells? They're going to lyse, so these will lyse. Of course, in this tube, the complement is going to be consumed. So there won't be any complement, if there's enough of these complexes here, there won't be any complement that's going to be available to bind to these antibody-coated erythrocytes, and you will not get any lysis. So by comparing the amount of lysis that you get in this tube versus this tube, you have some measure of the amount of antibody. The more antibody that there is there, the more complement will be consumed, the less lysis there will be in this tube. All right? So you just determine the amount of lysis in this tube compared to this tube, and you can that gives you some information as to the level of the antibody in these tubes, in the patient sample. Okay? All right, any questions on those?